All right, let's go ahead and get started. Thanks all for being here. We are very excited to have Dr. Kim presenting at our Department of Nursing Grand Rounds today. He is a professor of medicine and founding director of sports cardiology in the Division of Cardiology here at Emory, and additionally holds an adjunct professorship in the School of Applied Physiology at the Georgia Institute of Technology. He received his bachelor's at Emory and was a Fulbright scholar before attending Vanderbilt Medical School. He completed his residency in Med Peds at MGH and then cardiology fellowship here at Emory and was our chief fellow in 2013 to 2014. In addition to his clinical role, Dr. Kim conducts NIH-funded sports cardiology research at Emory. He's also the team cardiologist for the Atlanta Falcons, Braves, Hawks, United, and Dream, and for sports medicine at Emory and Georgia Tech. He consults for numerous other NCAA Division I sports programs and is a member of the NBA Cardiac Advisory Committee and the NFL's Cardiovascular Task Force. He's the co-medical director of the AJC's Peachtree Road Race in Atlanta and is the current chair for the American College of Cardiology Sports and Exercise Cardiology Consult. So we are very excited to learn from him today. Thank you so much for being here, Dr. Kim.
Well, thank you so much for the invitation. As mentioned, it's always such a privilege to speak at your home institution. So happy to be here. And it's a perfect time. I'm going to talk about the most recently published 2025 AHA ACC scientific statement, which was basically an update on clinical considerations for athletes with heart disease, the can you play with heart disease question for numerous cardiac conditions. And this will be a brief overview as it relates to the discussion of the why now, so the rationale for why this document was necessary as far as updates, and then a very high level overview of the what's new. And I think this is relevant not just for general cardiologists, but across the scope of internal medicine. Of course, competitive athletes at all levels, including older recreational athletes, are seen across all clinics, all specialties. And this question arises, and because, as you will see, these updates are fairly dramatic as it relates to what we deem as reasonable, I think it is important for everybody to have this discussion. Many of us, when you hear the term heart disease and sports participation, there's that knee jerk, oh, well, they can't play. They must have to be medically disqualified. And as you'll see, there's been a massive shift as it relates to how we approach this. So we'll get into this right now. So here are my disclosures. You heard all of them already. I'm very privileged because Emory Healthcare, and this is a nod to Dr. Scott Bowden, who's really driven this, but we are the healthcare sponsor for literally every professional team in town. So I wish I could brag and say this is all me, but really it's a downstream benefit for all the work that's been done on the sports medicine and orthopedic side. All my research funding relevant to the cardiac care of athletes and really related to this talk. No relevant disclosures outside the fact that I obviously take care of a ton of athletes. So here are the two documents. They were co-published in February, both in the journal, the American College of Cardiology and Circulation. And as you can see, it was such a privilege and honor to chair this writing committee and a chance to acknowledge all of the authors, primarily the other vice chairs, Aaron Bagish, who's actually in Switzerland now, and Dr. Ben Levine, who's at UT Southwestern. And I'll acknowledge really the entire writing committee at the very end. But it's important to remember that while this is an update, this really falls in the line of over 40 years of documents in the space. So many of you may remember the old Bethesda Conference proceedings. So these were originally published in 1985, and the updates have come essentially almost every 10 years or so. So 85 was the original document, updated in 1994 and in 2005. And in 2015, this was the first scientific statement where there was a shift in a co-publication, co-sponsorship between AHA and ACC. And it was around this time where we began to see a shift and a focus more on the athlete rather than just a paternalistic type recommendation. This is, of course, the practice of shared decision making, which encompasses really all of clinical medicine. But it's important to note that actually in this 2015 document, the term shared decision making actually was not used. You will not find that term listed in the document, but it certainly is addressed as it relates to a couple cardiac conditions. But there was still a heavy emphasis, you can see even in the title, on disqualification recommendations. So why the update? Well, since 2015, we now know that really the compilation of these old documents and what they stated is really outdated. We've had science, certainly over the last 10 years, there's been what I call a boom in the space of sports cardiology science. And a lot of this science, as we'll talk about, focused on outcomes of athletes with heart disease who chose to return to play and showing that actually the risk may not be as prohibitive as we used to think. And this shift in philosophical approach, of course, this is moving away from this paternalistic type paradigm where we tell the athlete what to do. But again, the acknowledgement that shared decision making is really the appropriate way to manage all patients, really, in all disciplines in medicine. So let's take a deeper dive into each of these, and we'll talk about shared decision making to begin with. So, of course, I don't have to tell everyone in this audience that shared decision making is an ethical imperative. We believe this, and we practice this not just in sports cardiology, but certainly, as mentioned, in all facets of clinical medicine. What's really interesting, actually, is this concept in sports cardiology is actually not new. So I'm showing this viewpoint that was written back in 1994, and it was led by Ben Levine, who was the vice chair for this document, and James Trey Gunderson. Now, if you wrote this back in 1994, you would probably not be surprised to hear that this was not very popular. And actually, I'm sure if Ben had presented this at a medical meeting, probably be afraid that people would boo him off the stage. This concept that the patient and the athlete should be involved in the decision process. But really, shared decision making is, and again, this ethical imperative, and it fits within the pillars of medical ethics. We know there has to be an emphasis on patient autonomy. The athlete deserves to have their voice heard in this process, doing what's best for the patient. So, of course, focusing on benefit and this concept of trying to do what's in the best interest of the athlete patient. The medical ethos of non-maleficence, that's number three. Of course, that is the principle of do no harm. And then lastly, ensuring that there's justice within the process. Again, that we're thinking in the best interest of the athlete in this case. And in sports cardiology, now in 2025, going back to 2021, you can see this was a state-of-the-art review that we wrote on the concept of shared decision making in sports cardiology. This is well accepted that we need to shift the focus on the athlete, and rather than telling them what to do, again, this practice of incorporating them within the decision. Now, we don't have all the answers yet. There's still many uncertainties, and this was a viewpoint that I wrote with Neil Dickert, who we all know as one of our colleagues here in the Division of Cardiology, just noting that this is not necessarily evidence-based from a qualitative type science point of view. And when you think about how physicians perceive risk relative to the athlete, certainly risk perception and differences that may exist between the physician and the athlete. There are certainly pitfalls that can exist where an athlete who's potentially engaging in shared decision making with a practitioner may not have the same type process across the board. And that certainly should be the goal as we move forward, trying to refine these practices while at least acknowledging up front that this is an important principle that should be incorporated in these processes. So, number two, we've had a lot of scientific advances, as I mentioned, as it relates to the safety of competitive sports for athletes with heart disease. Can't show you all the studies, so here's just a handful of some of the seminal studies over the last decade. Even going back prior to 2015, we began to learn that athletes with congenital long QT syndrome and athletes with ICDs actually were more safe to participate in sports than we used to think. Again, those used to be automatic disqualifying conditions. And in 2015, it was acknowledged that competitive sports for athletes with defibrillators or athletes with long QT could potentially be considered. Since 2015, we've had more prospective data, again, outlining the safety of athletes when under appropriate care can participate almost in any competitive sport with either of these two conditions present. But we've had more data now. I'm going to take a deeper dive as it relates to hypertrophic cardiomyopathy as well as other genetic heart conditions. So Perhaps some of you are familiar with the Live HCM study. This was published in 2023. It was led by Rachel Lampert at Yale, as well as Charlene Day at Penn. And this was a large study. It was actually about 700 patients with HCM who participated in vigorous exercise, compared observationally to about 700 patients with HCM who were more sedentary. Now, these were individuals who were engaged in vigorous activity as defined by AHA recommendations as it relates to physical activity. So, not quite a one-to-one comparison for competitive sports. But when you look at these two groups across time, and again, this was a composite adverse cardiovascular outcome endpoint, you can see the Kaplan-Meier curve on the slide almost superimposed, clearly no difference. And there were, I can't remember the exact number, but certainly there were competitive athletes that were included in this study. Perhaps more generalizable was this second study. This also was also published in the spring of 2023, and this comes from numerous high-level sports cardiology centers across the US. And here, this was an observational analysis following close to 76 elite athletes. So these were NCAA D1 athletes as well as professional athletes. All of these athletes had underlying genetic heart disease conditions. The most common were long QT and HCM. And each of these individuals, after engaging in shared decision making at these institutions, chose to return to play. And this was a study following for outcomes. So over 200 athlete years of follow-up were included in this analysis. The two key points to keep in mind. Number one, this was not a cherry pick study. Hey, let's just pick the most lowest risk HCM athletes that exist, somebody with perhaps a wall thickness that just crosses over the line of pathologic, no family history of sudden cardiac arrest or scar. As you can see, almost 10% of these athletes actually had a prior history of cardiac arrest. A third actually already had a primary prevention ICD placed. And across these 200 athlete years of follow-up, you can see there were three athletes of these 76 that had an adverse cardiovascular outcome, only one of whom was actually during exercise. So that's an important point to keep in mind. And there were no deaths. So the overall adverse cardiovascular event rate for this analysis was about 4%, which I would submit certainly not zero, but also not consistent with what should be deemed as a prohibitive level of risk. Now, there were limitations. I actually had the privilege of writing the editorial to this study, and there were a few key points to keep in mind as you review or read this study. Number one, almost three-quarters of these athletes were initially disqualified. So, as we continue to emphasize this concept of shared decision making, clearly we have a lot of work to do, even when we're trying to emphasize this within sports cardiology, as most of these individuals were upfront told you can't play sports. We have to keep in mind that shared decision making is not a rubber stamp. We cannot abrogate our duty as sports cardiologists or, frankly, any practitioner just to say, oh, yeah, I read these recent guidelines or I heard that we should practice in shared decision making. Doesn't really matter what type of risk you may have. You can play competitive sports. Clearly, not everybody with HCM is safe to play competitive sports. So we have to remember, and you have to continue to engage in the appropriate risk stratification procedures. And remember that these are high risk conditions, regardless of the fact that some athletes are now playing sports. Specific to this analysis, this question of generalizability, these are all high level athletes that had unlimited resources at their fingertips, professional athletes. Most of these were D1 athletes at the Power Four conference level. And something that I feel very passionate about, this question of healthcare disparities, remembering that most of the athletes, even in the high level sports cardiology centers that exist, are athletes who are high school athletes. Many may come from under resource neighborhoods who just don't have access to the type of testing and referral. So, how do we consider this population as well? These are important questions for the future. And just specific to this study, of course, these were high level sports cardiology centers, so the concern of institutional bias. And we just seen more outcomes data. So I'm not going to have a ton of time to talk about ORCA, but I will at the end. This stands for the Outcomes Registry for Cardiac Conditions in Athletes. This is a registry that's being conducted across the country, and now it's spreading internationally. I'll talk a little bit about this at the end. But the whole point of this registry is to follow athletes with heart disease and follow for adverse cardiovascular events as they continue to engage in sports and how they engage in shared decision making. So this is an important point for the future. Now, going back to the guidelines, other landscapes have changed as well beside these two principal points. We've had other guideline documents. So For those who aren't familiar, we have a document focused on how to interpret the ECG for the athlete. In 2024, the Heart Rhythm Society published a document focused on the arrhythmias in athletes, and not just athlete-specific documents, but guidelines and relevant to non-sports guidelines, such as those for hypertrophic cardiomyopathy, that are just not consistent with the 2015 recommendation. So if you look at the HCM guidelines, which were just updated in 2024, and even going back to 2020, they acknowledge that competitive sports can be considered. So a far cry from 2015, where it was stated that regardless of whatever phenotype you have, you should not be playing competitive sports. Of course, I hate to harken back to COVID-19. It's a nightmare for all of us, but we did go through a once in a generation pandemic. So the need to consider COVID-19, long COVID as it relates to these type considerations for athletes. But the bottom line is this: the standard of care at expert sports cardiology centers really opposed essentially the entire old 2015 recommendations. So, what you have is an unequal playing field. If you're an athlete that's unable to seek care at Emory, for example, and you're seeking care at maybe a center out in the community, or you just don't have sports cardiology resources, you're probably not going to have the same outcome. So, inequitable outcomes in the discussion of competitive sports for athletes were out there. And so we needed a new updated document for all practitioners to reference to understand that there needs to be this emphasis on shared decision making, and that there's signs now to guide the fact that in many conditions, it's possible that an athlete could return to play and return back to competitive sport. So that was the purpose of this document. If we start getting into some of the details now, this is how the 2025 scientific statement is separated. It's separated into sections encompassing the entire landscape of general cardiology. And each of these sections were comprised of expert task forces. These task forces put forth a clinical consideration table in each of these sections to guide the practitioner in terms of how to think about competitive sports. Now, we did have some new sections added specific to the 2025 update. An entire section focused on the importance of shared decision making, which we'll talk about in a little bit. A section on the master's athlete. So, how do we define a master's athlete? This is an individual which is older than 35, engaged in high level type training. So, it doesn't have to be a professional athlete. It could be your high level marathon runner, your triathlete, your cyclist. This population never before considered in a sports participation guideline document here in the United States. So we included that section, and then a miscellaneous section. So we wanted to talk about conditions not previously included in these documents as well, such as athletes with pulmonary embolus, athletes with heart disease who are participating in more extreme type sports, such as that at altitude, or athletes engaged in scuba. And we actually included a healthy population for the first time. We talked about competitive sports for the pregnant athlete. Again, never before considered, and really a point to emphasize that we need to uh, include pregnant athletes and think about them in future studies as it relates to competitive sports. So that population is well included in this specific document. Now, we have to talk a little bit about definitions because many of you may, after this talk, peruse this document and see where some of these updates are. And of course, we refer on scientific statements from AHA and ACC and other important disease processes as well. And for those who don't know, AHA and ACC and scientific statement formats have completely moved away now from class of recommendations and level of evidence. Those are reserved specifically for guideline documents. And while we consider this as a guideline document, it wasn't published as a guideline document. But we wanted to come up with terms that were consistent with the class of recommendation, level of evidence type of language, so readers would understand what we were talking about. And so here we have the terms that we use and the intended meaning listed. So for class one type recommendations, where we either have a high bar of evidence, or it's just consistent with the standards of care in clinical medicine, we use the terms should not, and can. For class 2A type language, where we know we have a high level of evidence, maybe not randomized controlled trial type evidence, but a high level of evidence, we use the term reasonable. Where it's still only expert consensus opinion, a 2B type recommendation, we use the term can consider. And we took advantage of the fact that we weren't using class of recommendations. And there's that gray zone. Sometimes there are conditions where you have evidence, but it's just not to a 2A level of evidence where you're really telling folks, hey, you should probably be doing this. So we use the term reasonable to consider to encompass that gray zone. And then importantly for class three type language, again, we wanted to move away from this concept of medical disqualification. For all intents and purposes, we really shouldn't be disqualifying any athlete solely based on a specific diagnosis. You want to still incorporate shared decision making. And so we use the terms risks may or risks likely outweigh benefits. All right, so I'm going to get into now to this high level overview. And before I get into this, it's important to acknowledge again that this was a massive shift in terms of this document. So I can't possibly go over every single section. As you can see, we essentially go over all of general cardiology. But even in the sections that I'm not going over, such as congenital heart disease or in this miscellaneous section, understand that there were significant changes from prior documents. So if you're taking care of this population, if there are some cardiologists listening to this talk, please ensure that you review these tables because what you'll find are probably differences from how you thought through this in the past. So let's go through some of the high level updates, and we'll begin with section one, which was focused on sports classification. In the past, we classified sports in this nine panel. So you can clearly see here now, sports are not in any sort of nine panel box classification. They're now placed on arcs. The old classification was basing sports more on percent VO2 or percent maximal contraction as it relates to strength sports and how competitive sports fit within this equation. But we all know that it's much more complex and there are many more nuances. The perfect example would be golf, right? So on the course, you're expending very little energy. But if you're a competitive golfer, and I call this the Tiger Woods effect, these guys now participate in a lot of training. So for those who play golf and are familiar with the names Dustin Johnson, Brooks Koepka, Bryson DeChambeau, these guys are jacked. They spend a lot of time in the gym. They place a lot of pride in how they train. And so that has to be taken into consideration. You really shouldn't place golf in this low endurance, low strength because of differences in training. In other sports, there's also differences in terms of time of season. In other sports, such as swimming, you're going to have differences in training based on stroke. For American football, a lineman is going to train differently than a wide receiver. And so all of these nuances have to be recognized by the sports cardiologist or the practitioner when engaging in shared decision making when you're talking about competitive sports if this athlete has heart disease. And so we wanted to place more on this continuum just to acknowledge that. In section one, we also talk about oral anticoagulation. And believe it or not, in prior iterations of this document, anticoagulation wasn't touched on to the detail that we decided to touch on this in this 2025 document. So we use this kind of traffic light separation, and we also talk about bodily collisions in the form of either collisions or impacts. Bodily collisions being two athletes who collide with one another, bodily impacts. Think of the downhill skier who loses control and crashes into a tree. And we wanted to think about collisions or impacts also at the type of velocity these type processes could occur. And in the green, these are collisions or impacts that probably are just not going to occur. And you can see some of the sports listed here. And if there is any sort of collision or impact, the velocity is probably going to be more at a low type velocity. So here you can be on your DOAC, you can be on anything, and you don't have to worry about it. The sports in red, here we have either collisions or impacts that are occurring fairly regularly, and the velocity is probably either moderate to high. So a boxer, American football as your examples, downhill skier. So here the risks likely outweigh the benefits if you're trying to counsel that athlete who is on full oral anticoagulation. But what you see here now is this yellow column. So there's always a gray zone, right? And there's going to be those sports where, you know what, you can have collisions or impacts. Maybe they occur, and if they do occur, maybe the velocity could be high, but it's just not as straightforward as these sports in green or red. And I don't have this circled here, but if you can see my cursor, you'll note basketball is in this category. This is quite interesting for you NBA fans out there. And by the way, tonight's opening night for the NBA. People remember the story of Chris Bosh, right? Chris Bosh actually played at Tech and had a great NBA career. And this is not violating HIPAA. We all know that he was diagnosed with thromboembolic disease that was recurrent, and he was placed on full oral anticoagulation. He lost his career. Well, now we're putting basketball in the yellow. So it'll be very interesting over time when you think about athletes on full oral anticoagulation who fall into this category, how shared decision making can actually potentially now play a role. And maybe you'll see basketball players able to participate on full oral anticoagulation. So a pretty significant update. Shared decision making, as I mentioned, this is not necessarily related to a condition, but just talk about how we think about this, acknowledging that we should have a focus on more qualitative science to really refine these practices. But in sports cardiology, and probably really in any field, you think about this through three phases. So in this first phase, you just got to make sure you have the right diagnosis. And not only that, you want to move through appropriate risk stratification for the diagnosis with appropriate testing and assessment. Once phase one or the good doctoring phase is complete, now you shift to phase two. This is actually the phase of shared decision making with the athlete, which takes the longest. This is all about the education, where you're bringing in the other stakeholders, the family members, the athletic trainers, the team doctors, the agent, the athletic director, you name it. And here we're assessing the athlete's values, we're providing education. And this is where you want essentially time invested to the process. This is never a 10-minute visit in the clinic. And in fact, if I have a new diagnosis of HCM, for example, we are not talking about playing sports on that first visit. It takes a while. You're going through the risk stratification process, and you want to ensure that everybody really understands what we're talking about as it relates to risks. Once you assess this, then you move into the final phase, which is the implementation phase. Either the athlete is going to return to sport and has the support of the other stakeholders, and now you're focusing on that return to play conditioning plan. You're focusing on the emergency action plan, of course. And again, this process never ends. There's longitudinal clinical surveillance, and you're re-engaging in shared decision making really at least at an annual basis. Maybe the athlete or at some part of the process has just felt best to move away from competitive sport. And now you're still counseling on health-based exercise counseling. So, what is the new exercise prescription? And that is certainly the focus in that other arm. All right, let's continue to move through some of the major updates. We're going to talk about pre-participation screening. Everybody's aware of this controversy of should we include a pre-participation ECG? Many people have very strong opinions. Well, what have we learned over the last decade? Well, we still don't have affirmative data that screening ECG saves lives, save one study from Italy. Every other study has never reaffirmed that. So it's highly controversial. But what we do know, if you include a screening ECG, in addition to a pre-participation history and physical, you will improve your sensitivity well upwards of about 95% of detecting potentially relevant cardiac conditions associated with sudden cardiac arrest. So because of that, what we actually have is now an upgrade. We state that a screening ECG is actually reasonable to include because there's just no doubt as to the value of that screening ECG. But there are two critical caveats. Number one, you have to make sure you have the right expertise in play interpreting the ECG. And you have to ensure that you've carefully thought through those downstream resources. So if you're screening a cohort of athletes, you better make sure that every athlete has the same access to the referrals and the testing. Otherwise, you could potentially be hurting people, particularly with the concern of false positive ECGs. And I'm going to get back to that in a minute. So it's not just that screening ECGs are reasonable if those two caveats are in place. There are no data to suggest that screening echo or any other additional testing adds value. So you really shouldn't be including that except in maybe select populations, such as a professional sporting league like the NBA, who does include screening echo. And of course, we emphasize the emergency action plan. So I want to get back to this idea of false positives. So this was a really nice study. This was after the 2017 international criteria were published. It comes from the UK. And this is where we cite this false positive for the 27 international criteria of about 1.5%. But here's the problem. If you look at false positives by self-identified race, no matter what ECG criteria you use, including the most updated, where we have the best sensitivity and the best specificity, what you'll find, Black athletes have double the amount of false positives. And we don't really understand why, but that's obviously a clear concern now if you're thinking about mandated screening, particularly if you're including minorities who may come from under-resourced neighborhoods. Again, the chance that you may actually be hurting individuals. Let me give you a real-world example. This is a screening program I was involved with a few years ago, so I'm not making these numbers up, about 300 athletes were included. Anybody who had a clinical concern or had an abnormal ECG was flagged. 36 athletes, and turns out actually in this screening program, these were all abnormal ECGs. And look at the discrepancy. These were almost all essentially Black athletes. And essentially all of these athletes had a normal outcome as well. So why do I bring this up? Because you have to consider the unintended consequences when you're just saying, you know what, it's just a piece of paper. Let's just get that screening ECG. And we're going to save lives. Number one, you don't know if you're saving lives. And number two, if you don't have those two critical caveats in place, you may be forcing a lot of undue financial and psychological stress due to time away from sport, maybe full medical disqualifications. And we have to remember that when we're thinking about screening. And this is important because if you look at states right now in Florida, they just passed a law to mandate screening ECGs for all high school athletes. And we're trying to push back on this narrative from a logistical or from an advocacy standpoint. So I think everybody should be aware of that on the internal medicine side as well. It's a very complex question, but we really shouldn't just think that screening ECGs is a slam dunk. We should all do it. Section 4 was on genetic cardiomyopathies, and up front, we have this statement. Having a genetic cardiomyopathy should not lead to a uniform disqualification. And that is a massive move away from prior guideline documents. In this section, we're talking hypertrophic cardiomyopathy, dilated cardiomyopathy, and arrhythmogenic cardiomyopathy. We make the point that this concept of LV non-compaction really doesn't exist unless you have an associated DCM with the trabeculation or HCM. Hypertrabeculation in the setting of normal heart function in a normal heart is actually just a normal variant. So for HCM, because of the data that I mentioned, a massive shift. It's no longer a you can't play sports. It's competitive sports are reasonable to consider. We have data now to rely on to state that when you have the right provider seeing this patient, utilizing appropriate risk stratification, competitive sports can actually potentially be considered. Now, one of the more controversial changes in this is the focus on arrhythmogenic cardiomyopathy. So this is the only genetic cardiomyopathy, and here I'm showing data from Johns Hopkins, where we know that ongoing intensive, really endurance exercise for patients who have arrhythmogenic cardiomyopathy, specifically with the desmosome mutation PKP2, we accelerate the phenotype of both the development of heart failure as well as the precipitation of malignant ventricular arrhythmias. And so that's why we've been pretty conservative as it relates to competitive sports specific for arrhythmogenic cardiomyopathy. But as you can see here now, we actually base our recommendations specific to PKP2 because this is where the data clearly show that endurance exercise probably increases your risk. So we do say that the risks of competitive sport, specifically endurance sport, if you have PKP2 ACM, likely outweigh the benefits. But the data are not as robust for gene-elusive ACM or non-PKP2 ACM. And again, if you're seeing the right provider, if you're engaging in the right discussions and risk stratification, maybe competitive sports can be considered. Again, I hate to talk about COVID because it just brings back nightmares for all of us, but I would submit that one of the highlights, or when we think about COVID-19, many of us really think about the impact on sport. And really, this was the day the pandemic probably hit home for many of us. I don't think I'm as biased as I know I am as it relates to sports, but this was the day that the NBA was canceled. I think we all remember when athletes, these players were pulled off the court, and all of a sudden the Masters is canceled, the Final Four is canceled. And it really became very real that this was obviously a very serious event. So why am I bringing this up? Because one of the offshoots as it relates to sports cardiology was a lot of science now focused on athletes with potential COVID myocarditis. Now, this was a study from the Big Ten. Where in the Big Ten conference, all of the athletes who were screened prior to return to play after a COVID infection actually got cardiac MRIs too. So there were almost, I believe, 1,700 or 1,600 athletes who had longitudinal cardiac MRIs performed. Now, this study had limitations, and I don't want to get into the meat of it, but what was observed in the 2.3% or the 37 athletes who were deemed to have myocardial inflammation after COVID was on repeat analysis with cardiac MRI. After only 4 weeks in a few of these athletes, there was complete resolution of myocardial inflammation. Now, granted, this was SARS-CoV-2. It wasn't any other respiratory virus. But because of the data that exists, we had actually an upgrade as it relates to the change of how long do you have to be away from competitive sports or exercise after the diagnosis of myocarditis. For those who may not know, the original recommendations were 3 to 6 months, but that was based on very limited animal data. There was never any human data to support that degree of restriction. So, with these data from the Big Ten COVID 19 registry, we actually changed the recommendations to state that after 4 to 6 weeks, you can consider proceeding with repeat risk stratification, as long as you already had a athlete who had a prior cardiac MRI with normal function, and of course that athlete has to be completely asymptomatic. But at that time, one can proceed with repeat risk stratification with a repeat cardiac MRI, as well as repeat exercise testing to assure no provocable arrhythmias. So that's a significant change. In section 5, not only is there a discussion of myocarditis, but I'm not going to get into the SARS-CoV-2 considerations, but just to highlight that you clearly don't need to screen athletes after SARS-CoV-2 infection anymore. And really, it's just those who have a high clinical suspicion for myocarditis that require assessment. An important point is when you talk about athletes with valvular heart disease, for those who aren't familiar with the concept of exercise-induced cardiac remodeling, when you're engaged in a high level of training, the heart dilates, it enlarges. And so, in the general population, when we think about intervening on valvular heart disease patients, we rely a lot actually on cardiac dimensions, particularly for those individuals who may have severe mitral regurgitation but are asymptomatic. That's challenging in athletes because you may have an athlete with severe MR who's an endurance athlete, and their ventricle is going to be dilated just because they're an endurance athlete. So we remove these absolute cardiac measurements. You shouldn't be using the guidelines that we use for the general population. And this is kind of the art of sports cardiology, where there needs to be that nuanced opinion from whatever expert sports cardiologist is involved as it relates to potentially intervening on these type conditions. We talk about mitral valve prolapse as well as other conditions as well in this section. I want to talk a little bit about aortopathy, again, kind of through this whirlwind tour, a little bit more organized in the 2025 document compared to past iterations, where we talk first about athletes with bicuspid aortic valve. We know there's the association with bicuspid aortic valves and aortopathy and aortic aneurysms. We talk about hereditary thoracic aortic diseases such as Marfan. And there's this entity where we have unexplained aortopathy. So a trileaflet aortic valve, clearly not syndromic appearing, but there's the presence of pathologic aortic dilation. Now, again, in the past, we have been very conservative with aortopathy because of the concern for aortic dissection. And we actually still remain fairly conservative, in my opinion, in these updates. But there is a little bit more of a liberal approach to competitive sports, particularly for those aortas that are not quite aneurysms. So dilated, less than 45 millimeters. Again, I'm not talking about Marfan. That's clearly where we're still much more conservative, but for these other conditions. But I'd like to remind everyone again that this is this concept of where we are in the continuum. We just don't have as much data as we would like as far as outcomes for athletes who have underlying aortic aneurysms. And I'll just highlight a couple points to illustrate this. So these are 20-year autopsy registry data from the NCAA. And just to highlight, again, when you look at causes of sudden cardiac death, despite how common bicuspid aortic valves are, what you see here is dissections are just not a common cause of sudden cardiac death. And if you look at the military, so this is 25 years of military data, over 6 million military recruits. There are 130 sudden deaths in this registry, about half due to sudden cardiac death conditions. If I were to ask, where are the aortic dissections? I'll just tell you as a spoiler alert, there were none. So it's just not a common cause. For as much as we're worried about aortic dissection as a potential cause of sudden cardiac death, we just don't see it as commonly as one would expect. And so to me, I almost feel like maybe we're where we were at with HCM about 15 years ago, where we started questioning, like, hey, are we being maybe overly restrictive here? And hopefully, as the science evolves over the next decade or so, we'll be able to continue to refine the risk as it relates to athletes who have underlying aortopathy. The masters athlete. And I want to spend a little bit of time here because, again, it's a little bit of a eye-opening experience when you talk about how we think of athletes differently compared to the general population. And you'll see what I'm talking about here in this section. But as it relates to the conditions that we discuss, coronary disease, atrial fibrillation, valvular heart disease in the older individual, unexplained myocardial scarring, and again, aortic aneurysms. Now, the reason why we define masters athletes greater than 35, that's actually based on definitions when you look at kind of national for USA track and field, how we designate the masters athlete in competition, it's 35. And so that seemed to be kind of a nice compromise to come up with an age determination. In the general population, I think 40 years of age is when you start thinking about some of the differentiating between a young person and an older person and some of the guidelines. But in this section, we draw a line in the sand at 35. So, where are some of the big differences as it relates to thinking about masters athletes versus people in the general population? So, the first is how we think about risk stratification. So, of course, when you think about asymptomatic patients and asymptomatic stress testing, of course, everybody should shake their head no, right? This is kind of that general teaching that we get during our internal medicine training. But for the master's athlete, we actually state, and this is consistent with what's actually in the European sports cardiology guidelines, that for those who are either intermediate or high risk, and these are based on your classic risk algorithm scores, which, by the way, were never validated for masters athletes, but reasonable to use in this population. For those who are intermediate or high risk, one can consider, again, we're using 2B type language, to proceed with more risk stratification, which can include maximal effort exercise stress testing. Now, when you stress test a masters athlete, this is a whole separate point of discussion, which is what protocol, because the Bruce protocol is probably not a great protocol to use for somebody who's a high end marathon runner. But that's above the topic of discussion for this talk. But again, you think about stress testing as well as maybe imaging those coronaries with coronary CT angiography. Now, for those who maybe have high risk features, or clearly for those who may be symptomatic and have abnormal testing, of course, you proceed with coronary angiography. And here is another big differentiating point between the masters athlete and the general population. Of course, I can talk about the ischemia trial. I can talk about any trial you want, courage. If I were to ask if we have an asymptomatic patient who's got an ischemic lesion, everybody in their training is and understands that there's no data to support improved mortality. And actually, medical management is really how one should focus care rather than revascularization. And so everybody's probably staring at this point here and wondering what the heck we're talking about. Because what we say is for stable coronary disease, but with a known ischemic lesion, not only with optimal medical therapy, but revascularization, this can actually be potentially considered. And so the question is why? Now, and I'm going to get to that. When we talk about the return to sport after acute coronary syndrome, actually, these recommendations are unchanged. You have to proceed with cardiac rehabilitation. And certainly in the risk stratification process after the fact, you want to assess what the LV function is, ensure it's normal. You want to ensure that there's no residual ischemia as well as provocable arrhythmias. And actually, for those individuals, a return to sport is certainly very reasonable. So, why this question of potential revascularization here, in addition to optimal medical therapy? And I will fully submit these are based on observational data. We do not have randomized controlled trials as it relates to this question. And that's why this kind of remains to be. But it really comes from observational data looking at outcomes of this population. I'll be gratuitous here and just talk about data that I've been involved with, but many are familiar with the RACER registry, both published in 2012, and actually we just published the update in JAMA this past spring, where we looked at outcomes of sudden cardiac arrest for individuals engaged in half and full marathons. And what we find actually is that the most common cause is due to underlying ischemic heart disease in this population of master's age individuals. And this has been replicated in other registry data as well. So it's not just US marathon and half marathon runners. But what you find when you look at these runners is actually a significant amount of underlying traditional CV risk. And remember, these are individuals that made it to the starting line. Obviously, there's a lot of other individuals who during their training might have been discovered to have underlying disease. And so the issue is, of course, is that these individuals are engaged way past their ischemic threshold for an extended period of time, and potentially that actually could increase the risk of an untoward event. And so it's really based on these data as to why we think a little bit more liberally as it relates to revascularization for this population. But clearly, you need to engage in shared decision making. You want to involve the interventionalist to make sure everybody's on the same page when you have a patient such as this. So I'm going to conclude. I want to make sure we have some time with questions with points of uncertainties in the future. And before I get to that, just another reminder again that I just glossed over the major highlights. I didn't talk about channelopathies and long QT or other arrhythmias. Some people ask the question, if you've had sudden cardiac arrest, can you continue to go or can you go back to sport? And the answer is maybe, actually, depending on what the diagnosis is, how the athlete's doing, what treatments have been implemented, and what type of risk stratification process. So there's a lot of meat within this document, and hopefully everybody has a chance to digest this at some point. But where are the uncertainties? As mentioned, a lot of these recommendations still are very much based on limited observational data, sometimes just opinion. And I gave you the example of the aortopathy where we really have zero data. There was actually a recent study published a couple weeks ago, but again, still very limited data. And so this is where ORCA comes into play. This is a registry. Emory's a subsite. The lead sites are actually in Boston at NGH, and University of Washington in Seattle. And it's looking at high school, collegiate, and professional athletes, all with underlying cardiac conditions. You can see what we're interested in is our outcomes, whether you went back to sport or not, how the shared decision-making process went for you, particularly for those athletes who might have been disqualified. And of course, the bottom line is we want more quantitative data to stick in line with outcomes specifically in these conditions. So this concept of disparities, I told you this is a passion of mine. We know that self-identified Black athletes have a higher risk of sudden cardiac death compared to white athletes, and we don't know why. It's my opinion that a lot of this are probably based on the same reasons why we see these same disparities in the general population. Of course, that being a focus on social determinants of health. So I think there is room for understanding of a lot of how this impacts the field that I'm in. And I think this needs to be a focus when you think about screening and, of course, outcomes as well. We need to involve our pediatric colleagues more. Pediatric athletes aren't just small athletes, just to take that colloquial phrase. We just published a piece from our council, again, talking about this growth of the field of pediatric sports cardiology. And that field is growing actually in this space. And I think there will be, again, extension as it relates to thinking about this population. As an example, we know for WPW that your risk of sudden cardiac arrest is actually higher for WPW pattern for that younger individual, the 13-year-old. And so you think about it when it's detected incidentally a little bit differently in that population than, say, it's a 22-year-old pro athlete. And so that all is some of the nuances that relates to this field. And then lastly, I want to get back to this at the end, which is this concept of advocacy in sports cardiology. And it's not just access to AEDs and the EAP. And having gotten to know Damar Hamlin, he is a true inspiration. He's really put an extreme amount of focus on this field. And I tip my hat, we all tip our hat to him because the focus on the EAP obviously didn't just start up a couple years ago after his event, but he certainly put a mega phone on this, the spotlight. And of course, the Hearts Act was passed, which is going to continue to promote AED access across the country. So that's a clear, important point. But this concept of mandated screening ECGs, whatever side of the fence you fall on as it relates to should we do them or should you not do them, I think we can all agree that mandated legislation, laws or mandated legislation to force all high school athletes to get a screening ECG is really a bad idea for all the reasons I mentioned. And while it may seem common sense, again, Senate Bill 1070, you can look it up in Florida, it was passed. They tried to push us in a few other states. At ACC, we've had advocacy efforts and have tamped down some of these efforts in a few states, but they're going to continue to arise. And there's reasons for that, which I won't get into that, but just know they're continuing to arise. And actually, we have a policy statement that we just wrote, which is going to continue this emphasis on why mandated ECGs are probably not such a good idea. And so I think that's a point of emphasis actually for the now, but also as we think about advocacy efforts for the future, which will continue to be incorporated in documents such as this. So here's the writing committee. acknowledge the two vice chairs, Aaron Bagish and Ben Levine. The pictures up there where some of you may know some of these faces. These are experts and leaders across the space around the country who were involved. But the names, you can't read them all, but these collaborator names, these are all the individuals that really put forth all of these clinical consideration tables. And so they were really more than collaborators. A point of emphasis was diversity across the board throughout all of these authors and collaborators. These aren't just the same, for lack of a better term, kind of older white men, like standard guideline documents in the past. You're really including that diverse spectrum, as we should, and not just by sex and by race, but also by experience, having folks who are earlier in their career, but also international collaboration as well, where we had individuals from outside the US. And that's our hope as we continue to make these documents in the space of sports cardiology. So it's 12:49. I think that gives 10 minutes. I want to thank everyone for your attention, and I'll certainly be happy to entertain any questions. Thank you.
Thank you, Dr. Kim. That was fantastic and really insightful about all of the changes while also covering a lot of information. And certainly, I imagine those of us over the age of 35 appreciate you referring to us as masters and not veteran athletes. So we appreciate your verbiage. Um, Looks like we have a question from Dr. Searles. NCAA stance on screening for college athletes.
Yeah, good to see you, Charlie. I haven't seen your face in a while, so probably all being spread out. But it's a great question. So actually, that's a really great point to bring up because I there was actually a consensus statement from the NCAA that was put out a few years ago. I think it might have been around 16 or 17. And on the concept of ECGs, they did make it a point to emphasize at that time that ECG screening can be considered if you, again, it's those two critical caveats. And so actually, I think the updated guidelines now will be incorporated in probably some updates from the NCAA just because it's been about 10 years. And because of all these other updates, I think it'll be important to encompass that. But I think it won't really change. And if you look at the NCAA, you actually find a mix. There are some universities out there that don't do ECG screening. Um, My own opinion, because we are saying that ECG screening is more reasonable based on the evidence, that it's going to be more hard pressed. And this is my opinion here, but at a large institution, I think it's hard pressed to say you don't have resources if we're just going to be honest, right? Particularly if you're at a university in the Power Four, where resources are clearly not an issue, particularly when they're doling out millions of nil contracts now to high level athletes. And so I suspect you are going to see more universities that will probably feel that pressure that they should be. But the reality is that those are the places where it does make sense because they do have the resources. Like you're not worried about a football player at, pick your ACC school or Big East school that may not be doing ECG screening right now that actually can't get that echo done if they really need to and want to. And so the concern I have, and this is why this is so important to emphasize, is again for the high school athletes or the athletes who go to universities at lower levels of competition who maybe it's a Division II school out in the middle of Midwest America and the closest tertiary care center is 3 hours away. That's where clearly the resource issue becomes a challenge. And that is, again, we wanted to be very clear when we stated this that people don't feel bullied into the point where, oh man, they're telling me I have to do screening ECGs. We're not saying that. We acknowledge that actually screening ECGs done incorrectly actually to me becomes more like a class 3 recommendation. That's where you can incorporate harm. So I suspect that language will be incorporated by the NCAA now as they kind of update maybe some documents as it relates to their policies.
Yeah, thanks, Jonathan. I mean, it struck me. I have a friend who actually was one of my college teammates. His son was a competitive cross-country runner in Maryland. Now it was a D2 school, but he was like
Yeah,
all met in the DC area, and he died in his dorm room. And so my friend's asking me like, what, how come we didn't know anything about this, And so I was just curious when you're
yeah.
screening. So
Yeah. Well, it's important that brings up two really important points. Number one, which is this concept that exercise is the cause. Absolutely, exercise-associated cardiac arrest is a concern, right? But dying at other times during sport is an issue, and that's relevant when you think about these conditions like HCM as an example, which is you can die from HCM in your sleep, much less just being a competitive track runner in this case. The other point is that the most common cause of sudden cardiac arrest or sudden cardiac death in the athlete is actually what we call ANSUD or autopsy negative sudden unexplained death. And that's been replicated now, not just in the NCAA, but also in other registry data sets from around the world. And it's actually really interesting. If you look at the causes of death, let me see if I can just flash back to this real quick. Um, this pie chart here. Half of these diagnoses, if you really dissect this, may not have been detected by ECG.
What's
And so
wrong?
that and so that's an important point to keep in mind as well whenever you think about ECG screening. And I'm not saying that ECG isn't going to detect conditions. And of course, I don't know what this individual you're referring to had. Maybe they had a condition that could have been detected based on the autopsy. But those are just kind of key points in mind to kind of think about as it relates to this concept. Again, some of this mandate, this push for these legislative mandates come from very well-intentioned organizations. Many of these people, I know they're directors, I work with them, I think they're wonderful people. And of course, they work with families that have had tragedy struck. I mean, nobody wants to see a young person die, much less a competitive athlete. And so I get it. I get this desire to be like, particularly in that circumstance. Um, but then when you try to think about the most appropriate way to do that, and then kind of some of these groups kind of pushing the lobbyists who then push legislators who aren't aware of some of the limitations of where ECG screening can go wrong, that's where these mandates come across. Um, and again, I don't want to get political here, but I do think it is very ironic that in the state of Florida, where they just passed a law to mandate screening ECGs for all high school athletes, they just pulled
no, that's
back vaccines. I mean, it's like it's almost hard. It's impossible to fathom. But anyway, that's a whole separate discussion. There are a couple other questions
We
in
do. We
the
have a
chat.
few more questions. So, currently, DeKalb County mandates all athletes, including those in elementary school, have a sports physical. Do you recommend screening AKGs for these athletes?
Yeah, no, this goes back to what I'm saying. Absolutely not, for all the reasons that I mentioned. The history and physical is one to where that's. I mean, there's not a state law. I think some states are going to start seeking this in part to prevent these ECG screening mandates because the reality is really across all kind of public school districts, you are required to have a 14-point history in physical. Um, and for and for those who kind of push back and say, because it is true, the sensitivity of a H&P on an asymptomatic athlete is terrible. It's like 10 to 15%. So it's then, well, you just told me the ECG, it bumps it up to 90. Why are we doing the H&P? Some of it is because it's still a touch point. It's an opportunity to have a young person see a doctor, get a blood pressure. You can potentially get an important family history. You can detect symptoms that might exist. And so it really does begin with it. I actually think the history and physical, for as much kind of um, criticism as it gets, the H&P isn't the problem. It's a poorly performed H&P. And whenever you do these mass screenings and you're spending 10 seconds with a 16-year-old and you say, "Do you have palpitations?" And they're shaking their head, no, I can promise you they have no idea what a palpitation is. And so they're just trying to get through the event. And so that's a challenge too, as well.
Is there any data for safety of returning to sport after ICD placement following
Yeah.
studying sudden cardiac arrest?
Yeah, and I just mentioned that briefly in the beginning. There is an ICD registry. It's actually up at New Haven, from Yale, and it's large. It's been going on for well over 10 years, and that is how we know that ICDs and sports participation, whatever the indication, even if for sudden cardiac arrest, um, actually is very reasonable. You worry about damage to the device. Is the device going to work? And actually, those two concerns, which is why back in the day it was the quote unquote disqualifier, now is not a disqualifier. And for most sports, you can. Now, we don't have data robust data for, say, contact sports like American football, ice hockey. Um, and I've changed my tune a lot on this. I used to kind of be very nervous about that. I just think we're at a stage where, as mentioned, when I talked about the aorta and HCM, we're just 10 years behind, where at some point the data are going to show that actually, even in contact sports, probably the things that we worry about a ton with defibrillators may not actually be as high of a risk as we think. But minus those contact sports, the data are pretty robust to support the safety of ICD implant under the right supervision.
Any other questions from our audience? Dr. Manning just wants to share her gratitude for this amazing talk.
Well, I really thank everyone as well. And if there are any questions, obviously I'm in the system. Feel free, anyone can email me anytime.
All right. Well, thank you, Dr. Kim. Thank you all for attending. Have a great rest of your day. Bye, everyone.